I'm going to be
Really
nice
nice.
and send you for free 50 of those to see if you're able to
Yeah.
make devices. And then and it'll be good if depending on how this conversation goes, is if you send one of those back to
Yep.
us.
Sure.
Uh, because then if you have issues and whatever, we can help you fix them. And
Yes.
then we can also help you package the whole device so that it looks like a medical device that can compete with the Philips and everything
Correct.
else as well.
Correct. Yes. So we were planning to get it done in Europe at some stage, and just solely because I have fondness for UK. I was in UK for 20 years,
Yeah,
so
yeah, yeah.
only because of that. And what did I want to say? The funding for it has to come separately and from private people, because currently we are funded by government and I can't pay for it outside the country.
Right, right.
Yeah. So that was the only restriction. So who is your designer? Is it somebody in America?
No, it's actually somebody in Serbia.
Oh, wow. How did you contact them?
My wife is Serbian.
Okay. So she knew the right people.
No, so we actually I live in Europe half the year. So we have a home in Serbia. And my kids speak Serbian and everything. So
Oh,
that's a surprise for you. Yeah.
okay.
So actually, quite a bit of my team
Yeah.
is out of the University of Belgrade in Serbia,
Oh, that's good. Yeah.
because it also reduces some cost for us. And then uh, uh, the ex Yugoslavia is incredible, right? There's
Hmm.
similar kind of background to the Russians, etc. So incredible talent. They don't cost as much for us. So we work with Serbians, and we work in Poland, in Ukraine, as well as in the UK as well. So I have a team presence in the UK as well.
Okay. So do
Yeah,
you have a lot of staff? How many would you have?
we have total of 21 people working in the company.
Okay. So
Yeah.
we have six and youngsters. So it's all, sort of carefully put together, and I seem to need to put a lot of input into it.
Yeah,
So a little bit of hand holding.
but your team
Yeah.
is good. I wanted to tell you that one of the reasons I suddenly felt like we should have a deeper relationship was even the presentation of the report,
Yeah.
the I guess the cardiology report. It was to the kind of grade that we want our solutions to match.
Yes.
So we see great synergy there, and um, yeah, I think the way that I'm thinking is that we can also help you uh, figure out a way to put your team uh, to to greater work, and also have them working across your products and our products, so that there's a more of a uniform feel, almost like a common branding
Hmm.
of the solutions as well, if you're open to that.
I think it should be. Actually, because of all the tech and the medical work that I'm doing, I would confess that marketing is not my forte. And I would like some other partner to come in who can market it even for India. And
And I have people I didn't mention that we also have a team in India, right? So I have people, and Pankaj was just here. So Pankaj and Vivek. So
uh-huh.
Vivek Sharma, my kids and his twins have been friends since kindergarten. So
Oh,
uh,
so you
so
know
we
them
know
for
them.
years. Huh.
We know them a lot of years. So we know them for almost 10 years now.
Okay.
Uh, and he had a company in India in education,
Hmm.
and he's actually starting to join our team to start growing our effort in India. And I think uh, Vivek and Pankaj, if you meet them, because I was
Hmm.
telling them about this. Actually, Vivek was on the call the other day.
Yes, I did meet
Yeah,
meet him.
exactly.
Yeah,
Yeah, but
yeah.
I just met Pankaj for the first time, and I think
Pankaj is
those.
engineering.
So he's actually an MD who's turned into a businessman in India, and he's now a multi-millionaire from working with Vivek's brother.
Oh, okay.
So he's good at and he's, because of his background in the medical field, he's been able to actually grow I think two different startups into acquisitions, and I think it'll be good to get on a call with him, because he's the right guy to actually help us on the business side of all
And
this, because
he's
he's so well
based in
connected.
India.
He's based in Bangalore.
Okay. So I too am in Bangalore. I think you're aware of it.
Yes, exactly.
Yes.
Yeah.
So that's one thing. So would you not consider partnering with a AI company or some medical device company who already has a distribution network?
Yes, we would, if we found the right people. It's just that we don't want to end up being turned into a different company, because I have very specific expectations from my company, in that I don't want to end up just being all about the money. We're all about impact, and
Yes.
some of these companies that you end up going into, they are all chasing after the dollar. So the quality of the
Yes.
AI,
So,
the
in
quality of the
fact,
product.
that is one of the reasons why, even though we finished the 12 lead ECG almost 18 months ago, and we did not enter the market because I wanted that academic freedom and, finish all the things that I wanted.
It
Uh,
has to meet a certain, yeah, a quality and
Correct. And adequate,
reproducibility.
yes, and it has to preserve my reputation and credibility. I
Yes.
can't market something which is halfway through and everybody starts saying, oh, it doesn't work.
Yeah.
So that was one of the things. We have started a lot of publications. We have published 7 papers, more, I think 5 on high frequency ECGs and 2 on holters. Okay. And I've just sent out 3 more papers, one on QT syndromes, one, and our capacity to measure that 5 millisecond QT changes. We have also sent out a paper on Holters once more, saying, the accuracy of what we can do. And how would you do 1,000 sample Holter records so that we can continue to do high frequency ECG. See, we want long term recording so that we can pick up ischemia much better. And the third paper was again on high frequency ECG, on what was the jig we set up to prove that these microvolt signals in the middle of noise is indeed high frequency ECG. So these papers have been sent out. I think we have material for another 10 straight away. We are in the process of, now we have automated our stuff, and we are in the process of publishing medical papers on equivalence and all this, x-axis parameters like p-wave, PR interval, all those accuracies.
Yeah, that's excellent. And I sensed when we talked, that was, we shared this common uh, intent and
Yes,
drive to actually be as high quality in our work as possible, and that this is not
yes,
just about getting
yes.
something out uh, and then if it all runs aground, you'll be doing something next. So for me, this this is a legacy project, right? This is going to be the most important work that I do in my lifetime.
Yeah.
And that's the way that I'm approaching it as well. And I see a similarity with you in that.
That's nice. Yes. So that's what we have been doing. Let me just grab my book so that I wrote down some points I wanted to ask you. So this is about the um, um, what you call it. Let me start with that. Have you done some protocols on what you want to work out in the hospital trial?
Yeah, so we've actually done uh, well, let me step back. Most of the work that we've done in the US right now have been around respiratory disease. So just using the infrasound to ultrasound e-stethoscope, right?
Uh-huh.
But we've also done one study at UC Davis, and that was for a cuffless blood pressure measurement using the device that I want, the one with a 4-lead
Yes.
EKG that we're looking
Yes.
at. So we have that protocol, and I'll be able to share it with you when we're
At
done
some
with this
stage.
call, so
Yeah.
you can see it.
Sure.
No, I'll share it with you today. We have an NDA in place, and I'm not worried about that.
Yeah.
So what part of the reason why I sent you kind of that big list of things that we want to do is that we would like to write a protocol, because the way that we collect the data for all those different diseases is exactly the same, and we're using exactly the same device. So we'd like to have one IRB protocol that can enable us to do all that work.
Yes, and it should be like that. It's clearly what we have done as well. But my clinical trial was much easier because I'm a cardiologist. I know all the cardiologists in Bangalore. And so we could just literally walk in. Of course, we have a CTRI and, all the approvals. But we could literally walk into the hospitals and do pretty much what we need. And so we have data on multiple kinds of patients. So we can study the equivalence, we can look at the minor details like microvolts and all that. So this is more like creating a registry, and from that, we are doing a lot of data work. So what is the kind of data that you need? Because what I'm seeing, maybe you can project that one slide where you have said how you will prove it, and there is a slide on you will access the clinical data, or shall I project it?
Oh, sure. Yeah, I don't know which slide you're talking about.
Huh.
I have too many slides.
Okay. So I'll just get that. Start now. Just give me 1 second. Um,
Because what I think is we do our studies a little bit differently from the way that you're doing them, and it'll be good for you to understand that
Yes,
little
exactly.
difference. Yeah.
That's why I was thinking that I should know exactly what you meant. So just give me 1 second. I think it's this one, the validation plan. Can you see that?
It's not coming up yet.
Okay. Is it coming up now?
No, for some reason, nothing is coming up on my
Oh,
side. I'm
let me
just.
just do that once more. 1 second. I'll just share screen.
It's saying you're presenting, but there's nothing showing up.
Okay. I'll just do that presentation once more.
Okay.
Um, it says I'm presenting now.
Ah,
Um,
okay.
you got
Yeah.
that?
Oh, you are you presenting from your phone?
Yes.
Ah, okay. You're very fancy. I don't even know how to do that.
Okay. Yes. I will.
Okay, yeah, yeah. So
That's
let me talk through let me talk
yes.
through this. Now I know what you're talking about.
Yes.
So the way, essentially what we want to demonstrate is we are equivalent, uh that we can train, right? So we don't try to go for equivalence right at the get-go, right? Because we're an AI company. So
Yes.
uh, essentially we're focusing, all the studies that I shared with you were really for the top line. So ECGs, echo, and carotid Dopplers, because
Yes.
that's the clinical gold standard for pretty much a lot of those uh, diseases that I shared with you,
Yes.
right? So, the first, first 500 patients that we're asking for are really just to train our algorithms, right?
Yes.
Is that we collect data from those patients, and our tests are just 10 minutes, right? To
Yeah.
collect data from the individual patient, and then we collect the the clinical gold standard ECGs, or maybe you send the people to, well, would prefer to have that done at the same time. So this is why most of the work that we've been doing in India has been actually done at a diagnostics clinic,
Mm.
because they can do the screening with our solution, and then use their equipment there. So we pay for an additional staff member
Yes.
that is just doing our scanning with our solution, and then the person goes through and does the clinical gold standard test, and then we pay um, the diagnostic clinic to share that data or images with us, right? Same with
Okay.
echo, and same with carotid Dopplers. It's essentially echo anyway, right?
Yes.
Yeah.
So we
So
are also doing pretty much the same, but we just capture it from the file of the local government hospital that has 600 cardiology beds. And it only works because I know them and they let me sift through the files. And we take pictures of the pages and then we sort of collate that data. Now, if you want, discharge records, that is very tough in India, and you can't go by that because they would not have summarized everything. If you want pharmacy records, I don't think you'll have it. And functional records, you mean the validation according to the test that you are doing, right? That is
yeah, so
echocardiogram
I just need the echocardiogram
and the
that we can
carotid
then.
Dopplers.
That's correct. And
And
the
you
echo,
want
and the echo,
just the images, not even a report.
we want the raw data.
Yes. And
Yeah.
so, how would you get the raw data? Like, would you specify which machine and you put in your own technician so that it's reliable, or how do you normally do it?
Yeah. So the the work that we did in for COVID, for example,
Hmm.
they um, people would, while they're waiting to get their RT-PCR and maybe CT scan,
Yeah.
they would be scanned by somebody who was trained by us on using our device,
Huh.
and then the diagnostic clinic would just use the same number for that individual to
Have an
send us
echo
the.
and a carotid
Yeah,
Doppler.
exactly, and the
Okay.
RT-PCR, and that's it. It was that simple. So they were making extra money from us because
Correct.
the patient was paying them, and then we were also paying them for the same data.
Okay. Okay. And
So, and that works.
how do you
Sorry.
ensure the quality of the technician and the radiologist?
Oh, because they we well we relied on them to actually uh, affirm the quality of the radiologist rather than us. And this is why I was saying to you that one of the things that we could end up doing in our relationship is to end
Yeah.
up setting up our own clinic where you have a qualified person who's excellent, and using the same machine, and we look after our machine properly, right? Because in
Yes.
the end, being able to get our own EKG system, our own echo, and carry the Doppler, it's not going to cost so much money. We can, with you as a cardiologist, we could actually set up that clinic around you, and you have junior clinicians and radiologists that are actually reporting to you, and all they're doing is collecting this data and providing free clinical services to, and that's how we get a lot of people coming to you, because we will offer all the services for free.
Okay.
And then
I
and
have
then level
to
42, yeah.
I have to think about it a little bit. So I work in the slightly upper middle class clientele, and
Yes.
they would look very suspiciously if I was just to offer a echo or something for free.
Well, it doesn't
And
have to be free, right?
it
So
doesn't have
I
to
was,
be free, and it
it
would
can be
partly
cheaper.
fund the, yeah, it can partly fund the clinical trial.
Yeah,
And
exactly.
yeah. So ECGs is given, that's not a problem. Echo is a given, that's also not a problem. Carotid Dopplers, I think we can train somebody specifically for that. So it's quite possible that, let's say, the echo technician can be trained in acquiring the images of carotid Dopplers. And you can also do image processing to get the degree of narrowing or whatever you're looking at.
Yeah, and then we can have an expert reader as well, one in the US and one here, one
Yes,
in India and one in
yes,
here as well. Yeah.
yes.
So
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 that
again,
will
I would
be,
say, sorry, Suganda, I was going to say, we don't start, carotid Dopplers are a little bit more involved. I would actually just start with the EKGs and the echo, and then we
that
can,
is under my control, so that's very easy. And we have
yeah,
already been doing it. We use a Welsh Allen, it's an American machine for
yes, yes,
ECG, and it goes
yeah,
to the cloud. So it makes it very easy for us to acquire the data. And we already have many people trained in it.
excellent.
So that's
Um,
not a problem.
and then for blood pressure and other stuff, we also use the Welsh Allen sphygmomanometer that we can, if you're not using the same one, we
No,
can also.
I am using the same one.
Okay,
Well,
great. Yeah.
Shannon or a Heine from I think I have one of Heine from Germany, and maybe two or three of the Welsh Allen.
Okay, excellent.
Yeah,
Yeah,
so
so I
that
would
should
start
not be a
with,
problem. Carotid Dopplers as well. I think training someone to acquire images is should not be a problem. That's a very easy one. And we also have radiologists that could get involved and just do those images.
yeah.
Yeah, that's not difficult. And so we will not rely on just discharge records. I think if you are looking at a one off visit to a clinic, because you're not looking at acute infarcts or anything, then getting all this data is not difficult.
And the rest, the discharge record, pharmacy records, and functional stuff, we can also uh uh that's not so important for the training part, but it will be important for the clinical and algorithm validation down the line as
So
well. So
if
we don't.
you have a sample of a discharge record and highlight the points that you need, then
Okay,
in that visit, I'm sure that can be done.
okay,
It's not difficult.
great.
So it is. I just wanted to go through it because these discharge reports are nowhere near what you will get from US or from UK. You might
Yeah,
have already experienced that.
yeah, yes, absolutely.
Okay. So that's what I really wanted to mention that to you. And functional records is what do you want? It's the valvular readings and all that, is it?
Yeah, yeah.
Okay. That is also not a problem. If they have had angio records, you can have it. Most of them may not have.
Yeah,
Otherwise, we will have to go to a hospital to acquire it. And in most of the hospitals, the quality of echo and Dopplers will become more of a problem, in the sense
yeah,
quality may be good, but there'll be a lot of variation and very subjective.
yeah, yeah.
Okay, we have so much of problem in even declaring pericarditis. I would say 1 to 1 that pericarditis after Pfizer vaccine, we don't give Pfizer in India. And I get
Yes.
most of the patients from Middle East coming here with Pfizer vaccine. And in them, at least till 2 months ago, I was seeing 90% of them had pericarditis.
Wow.
It's now the numbers are settling down, so at least for 6 months pericarditis is there, but if they go to another doctor and they just declare the echo as normal.
I see.
So these kind of subtle things, we really have to identify the right person to do it. If let's say your interest is in pericarditis and you're seeing how many people got it, then the results will be very different.
So this is great. So okay. Um, so you see how our plan actually aligns very well with what you're doing, and we are uh, that same um, diagnostic clinic is now doing maternal and fetal health for us right now.
Huh.
So they
So are
are
you
women.
actually picking up the fetal heart rate?
Yes, we can.
Okay. So this is with that device deployed on. So which device do you put there?
This one, the one with the 4 lead EKG.
The one I'm on, the page on.
Yeah, yeah. So that middle one, the one that you can see the sensors
Two
at the bottom.
sensors. Yeah.
Yeah,
So what is the size of this device?
it looks like a mouse. And in fact, I'm sending this to you.
Oh, that's
Uh,
very nice.
so
Huh.
so Pankaj, who's actually here, he's leaving today. He's gonna be coming with a device for you and a computer for you because right, it's all one thing me telling you about what this device can do. I
Yes.
would like you to see it for yourself. And then before we start writing the protocols and moving things forward, because
Yes.
I want you to be convinced and not have me tell you that this is how it works.
Sure. That's really good. Yeah. Um, that's very nice. I was also going to ask you to demo it at some stage, but this is wonderful. Is Pankaj coming to Bangalore?
Yes, he's leaving today. So actually, later on today, I need to catch up with him and give him because he's also taking a device for himself, and then he's bringing a device for you.
Oh, that's too good.
You see,
Okay.
I move fast, and I think and I
That's
trust
nice.
people, and I know people that I have a kind of the same wavelength as right away, and I think I have that same feeling with you, but now I need to earn your trust and to know that I'm not trying to take over your company. I'm trying to figure out how we can work together and actually move both our
No,
products forward
absolutely.
together. Yeah.
Absolutely. And so our plan, by the way, the company is owned by me, and still own about 99.5%, I think. And
You're so lucky. I own not as much as you do by a long shot.
okay, and my husband owns 0.1%. He's an ophthalmologist. And 0.4% is owned by Delhi IIT because they gave us a CSR fund of
Okay.
50 lakhs for 0.4%. That was 2 years ago.
I'd love to talk to your husband because we also doing some work in I'm working very closely with the
Oh,
ophthalmologist and the and dentist here for our um vision
okay.
detection, right? So we also have we have these data that we've collected, but we also have really good algorithms around machine vision as well.
Okay.
Yeah.
That's nice. Yeah. Gopal is a graduate from All India Institute years ago,
Okay.
and he also does a small device for amblyopia,
Okay.
specifically for amblyopia. But he's not into AI and this high technology. He's more into clinical work, and with his experience, he's made a simple device which seems to work brilliantly. And definitely, I'll put you in touch. Yeah. He's currently away on the big meeting for ophthalmology, All India Ophthalmic Society meeting, for which he was
Okay.
president a couple of years ago.
Oh, nice.
Yeah.
So
So,
you guys are pretty are very busy then. You're always traveling.
yes, I think we have busy. We have got busier as we got older.
Yeah. Yeah.
Yeah. So that's what it is. That sounds really good, Sasha. What about your company? Is it owned by you and your partners, or is there anybody else?
Yeah, so we in the US it works a little bit differently in that there's four co-founders. So you've met me, and I
Yeah.
think the other people were Mike, who's our systems engineer,
Yes.
and Andreas, who's our embedded electronics, MIT graduate from Germany,
Yeah.
amazing. He's the one who's actually making, who's improved the epic sensor on our side and all this other stuff, and
Oh,
then
nice.
Peter is the one that's doing the gamification, so the app development. So
Okay.
we co-own the company, and then we have some advisors that we have also given a part of the company, and then uh Eric Schmidt, from the
Yes.
ex-chairman of
Google.
Google.
Yeah.
So he put money into the company, as well as Berkeley Skydeck.
Oh,
So yeah, I'm the CEO and I'm also the chairman of the board, but I have a board that I take all this information to, and
yeah.
they essentially support the things that we're doing, and we're doing a lot of work in India and in Africa. I think I mentioned to you, because we
Yes.
want to make sure that these solutions are not being constructed in Wisconsin or somewhere where pale skin, everything works perfectly on pale skins, but then
Yes.
doesn't work on brown and black skins.
So you
So
want
that
the diversity and yeah.
right from the get-go, right? Rather than
Yes.
doing it at the end,
Yes.
and that's working really well at the moment.
Okay.
And the acquisition from Plessy, right? I'm the one who did that,
Oh,
and uh, we're in the process of actually even improving, because we're going to be setting up a factory to make the next generation of those the sensors that have embedded AI in each sensor, so that you don't have to do so much work for signal conditioning, signal processing, and all this other stuff.
hmm.
And it looks like we'll probably get that money to be able to do that. And that's why I was saying to you that we want to be able to manufacture these here in the US, and potentially in India as well, because then that can serve the Indian market as well as the African market.
Yes. I think there is a lot of push for semiconductors and chips in India right now,
Yes.
and
Yeah.
it may be easy to get some money as well.
Yeah.
So, what kind of would you set up a independent organization, or would you like to link with anyone who is already manufacturing semiconductors?
Well, that can be an additional add-on. The first thing, and that's what I was trying to be transparent about, is that we want to link up with you first, right?
Sure.
Figure out a way that we can work together. You keep your IP. You The 12 lead EKG market is yours. We're going to support you to make an amazing device that everybody will start using.
Yes.
Um, and then we will do the patch, right, as well,
Yeah.
and the point of need a device, that the handheld that I was showing you about. So I
Yes.
think, and then we have the e-stethoscope. So if you just think about those four devices coming out of Carditek as the products, because I don't mind if in the end we white label our solutions and they're being sold in India as Carditek, right?
Okay.
So it's one unit of solutions that look and feel the same. That's why I was talking about the interoperability and actually the visual presentation, so that the data looks similar, so that your patch, your 12 lead EKG can end up being interoperable, so someone can when they come and they do uh, the point of care 12 lead EKG, but they also have the wearable. The data will look pretty much the same to demonstrate
Yes.
that this is the same quality data. So that's where I'd like to go with you,
Okay.
if that's something that would wouldn't scare you.
No, no, I think I'm open to that. And I have absolutely no problems with it. What about, see, we are just about to, let's say, finish pilot trials where we are looking at 20,000 ECGs from each of our centers and probably four centers. And then the government wants us to do around 60,000 ECGs, and governments go slow in India, as you know. And
Yeah,
so we are looking at massive numbers of ECGs. And our interest is more into hardcore cardiology, where the data that we are giving is not available right now to EP guys or to the cath lab guys.
right.
Okay, that is the area. And then we would sort of slowly trickle down to general physicians, non cardiologists, then go down to the GPs, family physicians. And then we will also be looking at continuous monitoring in ambulances and in what is the other place? We wanted to actually put kiosks in various centers of the city where anyone can just walk in if they are having a chest discomfort and get the ECGs done. So we are concentrating much more on the cardiology side of things. We are not looking at wellness right now, although wellness can be looked at much later. But if we are collaborating with you, maybe you will be taking care of the wellness with your
Yeah,
gadgets because they need only about 30 seconds of data. And
exactly.
so we are looking at continuous monitoring and things like that. So if that would be fine, just think about it. And the other thing is that how would we coordinate, data and AI and all that? As far as I am concerned, till now, I have actually looked at increasing accuracy of acquisition and signal processing. I have not gone that much into AI, because we wanted to accumulate our own data, which has the diversity of India, and then start. The other problem is that MIT and other centers of data, which are freely available for others, they have been accumulated from 1998 till now.
Yes.
And that
Yeah.
data is not even annotated properly. There's so many mistakes, although I'm commenting on
Yes.
MIT, but they are not annotated. I would rather, we look at our own data, which is at least 1,000 samples, going up to 2,000 samples for restricted leads. We can, that's what we are accumulating right now. And so the kind of analytics we can have straight away from it, even without AI, is much better. For
Exactly.
instance, atrial fibrillation, you had mentioned in AI. we have the capacity, I would say, to actually eliminate the QRS waves, and we can measure the atrial fibrillatory waves, and hence predict who is going to respond to a defib and who is not, and whether this thing is chronic, and all that. You just put it together with the data of the, let's say, the atrial size. I think that predictability is nearly 98%. So I have not seen the level of AI we need. I would look more towards AI for, let's say, looking at let's say you can translate ECGs into sugar values or magnesium values, potassium values. Just do an ECG and you're able to say, look, this is by AI, I can tell you your potassium is very high. Those kind of things, definitely very, very interested. I feel that in the small numbers that we have, our accuracy is more towards 98, 99%. So even if we improve it in terms of costing, it costs us around 80 Indian cents, paise, for let's say reporting a regular ECG. And if we go into AI, it costs us 30 rupees.
Yeah. So you're speaking my language now here,
Nice,
because the
China. Yes.
no,
Huh.
because the most people require very complicated algorithms to fix bad data. If
Yes,
your data is good, you actually don't need that complicated
exactly.
analysis. So,
Yeah.
so what I want, and then this is why I also want to be working with you, is that if we create a large enough database, we're gonna
Yes.
come up with what I call generative transformers. So very simple transformers that actually understand our data really accurately, so that right at the point of care, you're providing your analysis as part of the report very simply. And that's,
Yes.
again, this is the whole idea, is not to make things so complicated that you don't even know what the algorithm is doing and what's picking up. Because
Correct.
one of the things that we've learned is that in speech, uh, for people trying to learn detect COVID from speech, is that
Yes.
if you they make someone talk about how are you feeling, and they're in a room that has HVAC running, right? Because they
Yes.
already have COVID-19, um, versus someone who doesn't have COVID-19, and they're not in an air with in a room where there's HVAC running, right?
Yes.
The air conditioning. So the algorithm is detecting COVID-19 not on the individual, but by the sounds that are in the room.
Correct.
But you can't tell, right? Because the algorithm is so complicated. So we want to get rid of all that mess, and
Yes.
actually have the data be what's driving the
Yes.
uh,
So
the,
it's
the
quite
outcome. Yeah,
possible that 2% or 5% of data that we get may benefit by going through an AI system because we can't
exactly,
diagnose it. But
exactly.
we should not be unnecessarily putting in 95% of it through an AI.
Yeah, yeah. So yeah, and I like this approach. So we've talked about kiosks on our end and stuff like that. So we can
Yeah.
actually share with you some of the kiosk designs that we have. And really, I see India ending up being ahead of the US in terms of this kind of technology. So that can be the first market, and then after
Yes.
that we go to the UK and to the US. So
Yes.
so this is why I really think um, working together, we can accelerate and have a huge impact, and then show that these technologies can start elsewhere and then come into the US markets
Yes. Yes.
later.
Yes, I think if you have, let's say, 1 million pieces of data and then you come into US, they
Yeah,
really can't fault you.
exactly,
Yeah,
exactly. Yeah,
that's fine. The last question, we were, as I was saying, we are in government funding, which is like
yeah,
very, very frugal. Okay.
Yeah.
We have spent only around $350,000 till now and
Right.
managed to do this. And so we were planning to go into investment funding, and some of the big VCs are willing to fund us. Do you think we should look for that, and would that suit you as well for Indian?
Yeah, absolutely. Right. So the way that I'm thinking, Sugandhi, is that Carditek stays independent. We're just another investor in that. We figure out how much of an investment we are making, both in terms of cash and also in terms of equipment. Uh, but you're not. I'm not trying to get you to become part of Level 42. We need your organization to stay separate, and you can make your own venture. Uh, Fundraisers and all this other stuff according to what you need. But
Yeah,
we would also like to invest in Carditek in terms of hardware, so that you no longer have to feel like you've got this big burden in terms of paying for hardware. We can take care of that. And then also in terms of technology, where we are helping you uh, prob troubleshoot to make sure that the solutions that are coming out end up getting a CE mark.
yes,
They're amazing. They're
yes.
beautiful, and people look at them and they they asking where are these made, and you're actually smiling and say these are made here. They came from here, right?
Yeah, no,
That's the
that would
magic that
be
we want to create
so.
together.
Yes, sounds like a dream. That's very nice, and definitely would like to collaborate with you. Maybe you got to get moving because of your children.
Yeah,
Yeah.
in 2 minutes. Thank you.
Okay. So, anytime happy to connect again. Let me also think about it and, let's work it out. I think whatever little differences, I'm sure we can iron it out. That's what I also feel. I think you mentioned that as well.
Yeah. So yeah, we trying to figure out a way to help each other here, and figure out a way to go forward. So
Yes.
uh,
And one more thing, Sasha, the data has to be kept in India. I think you're aware of that rule from the government.
yeah, so the way that we work with all this is that, and this is where we're going to be ending up going, even with the discussion with Pankaj, is that we're going to end up setting up an AI group within India to analyze all these data that we're working
Yes.
on. Right? Yeah,
That'll be much better. I
yeah,
mean, I think
yeah.
your analyzed data can be taken out,
That's true. Yeah,
huh? But not the actual raw data.
that's correct.
That's what the government has been saying. By the way,
Yeah.
our software was actually developed by my brother in he used to work in Google before,
Okay.
okay, and Facebook.
Okay. So what
Okay.
is he doing now?
Right now, I've forgotten what company he's working for. He's in AI. And but he could not carry on with our work. So right now it's shifted to India, but all my data is in American server. We are just about to transfer it here because of legal reasons.
Yeah. So are you talking about the presentation of the report? He's the one who generated all that.
No, no, that's me.
That's you.
Yeah. That's
Okay.
because
So
it's so much cardiology, right?
yeah, but I really like the way it was presented. I mean, it looks. I think it needs to be finished a little bit, but
Yes.
it looks really beautiful.
Yeah,
And we would like to help with that, and also make our data look exactly the same, even if it's
sure.
not EKG, but the phonocardiogram. So that this is why I was saying that the reports, if they start looking the same, that will be pretty incredible.
Yeah, it will be. And I think that, I think we both have the same idea that it should be presented so easy to the doctor that he should digest it within 1 minute.
Exactly,
Yeah.
exactly. Yeah. No, that's great. So let me. I'm happy you think a little bit. I know I've thrown a lot of stuff at you. Think a little bit about it, and we can maybe have another conversation on Friday, and then we can have start thinking about bringing everybody else back into that conversation that was on that call. Your advisors, because they might still have some questions, and
Yeah.
I want them to know that
Yeah.
I followed
They're
through.
more
Right,
like
I,
friends
I
and
sent
men.
you.
Yeah, they're more like friends and mentors because we don't
Yeah,
have
sorry,
a
you're breaking up.
formal. I said we don't have a formal board right now. It got
You're breaking up. I can't hear you.
no worries. I'll send you a mail.
Okay,
Okay. Thanks.
okay. Thank you so much.
Okay.
Bye bye.
Thank you. Bye.
What do you think? I actually just wanted you to listen to it. Do we just pause?